And everybody, I'm Renza from Diabetes Australia, and I'm here today with Sof Andrikopoulos to talk about a very important issue, which is other types of diabetes. But before I do that, I'd like to say that I'm joining this question and answer from the land of the Wurundjeri people, and I would like to acknowledge them as the traditional owners of these beautiful lands. And I'd also like to pay my respects to their elders, past, present and emerging, and any other Aboriginal elders who may be watching us today. Today we are talking about other types of diabetes, and this is a little bit different because usually we do all of these live, but the bit we're doing with Sof Andrikopoulos from the Australian Diabetes Society, we've recorded a little bit earlier on. Sof is joining us from his car, obviously. He assures me he is not driving while we're doing this. Is that right, Sof?
I'm not driving. Hi, Renza. Hi, everybody. Glad that you all join us, and I too would like to acknowledge the traditional owners of the lands that we meet on today, and acknowledge their leaders, past, present and emerging.
Thanks, Sof. Now today, did you know it's World Kidney Day?
It's World Kidney Day today, yes.
Yeah.
And the whole month is recognising women and how wonderful women have been in all facets of life, including diabetes, including in research, including in academia. So I would like to acknowledge the awesome and wonderful support that I have personally received as a scientist, with Marjorie Dunlop, who was a wonderful mentor to me, and all the other people that have assisted me in my journey. So thanks, yeah.
Absolutely. The theme for World Kidney Day is living well with kidney disease, and I know that we often are talking about living well with diabetes, and of course there is a link between kidney disease and diabetes. So I guess I would just like to say, if you need to have your kidneys screened, go and have a chat with your GP every year at least. I get mine done, and it's very easy now. I remember when I was first diagnosed, I used to have to do like a 48-hour urine collection. We don't need to do that now, not as a first screening check. So definitely go and get that done. And the other thing I want to say, Sof, and I know that you're totally on the same page with me about this, is that when people with diabetes are offered their vaccination, please go and get vaccinated. We are definitely part of phase 1B. This is adults. 1B, adults with diabetes. We're still not yet, I don't know where I'm going to be getting mine. I'm assuming it'll be at my GP. I'm waiting to hear, but phase 1B kicks off on the 22nd of March, which is Monday week. Keep an eye on our socials about this. Also keep an eye on your local Department of Health website, and of course the National COVID website as well. And all that information will be available as we know it.
And we should acknowledge the great advocacy that Diabetes Australia has made to ensure that people with diabetes are early on in the vaccination program. So wonderful, great work, awesome work. Thank you.
Thank you. And absolutely, I know, you know, as is the ADS and the ADEA, and we're very, very committed to ensuring that people with diabetes are very far up that list. So that's some good news. But Sof, today we're talking about different types of diabetes. We're often a little bit guilty, I guess, when we think diabetes, we think type 1, type 2, and forget that there are lots of others. We're not really going to focus on gestational diabetes today because there is quite a bit of information out there about that. We're going to talk about other sorts of diabetes. How many sorts of diabetes are there? Do we have a number?
Yeah. Well, we don't. And I think diabetes is quite heterogeneous. In other words, it's not one disease. But what gives you diabetes may not necessarily be the same factors or the same genetic background or the same environmental influences that give me diabetes. So in broad sense, we have type 1 diabetes, which we know seems to be a destruction of the cells that produce insulin in the pancreas. So it's quite an acute disease. And although, you know, usually it occurs in childhood, it can affect any person. So that's why we call it type 1. We don't call it juvenile diabetes anymore, because it can affect all ages. Then we have type 2 diabetes. And type 2 diabetes is usually linked with poor lifestyle, low activity, physical activity, and weight gain. And that is an inability of your body to produce enough insulin for the system to cope well enough. So in type 1, there's an absolute deficiency of insulin. In type 2, there's a relative deficiency of insulin. So there are sort of two broad categories that we have, but we know that even with type 2 diabetes, there's subcategories.
Yeah.
So there's been a number of studies now to show that there's at least 5 or 6 different types of type 2 diabetes.
Yeah.
Then I know that people may have heard of LADA,
Yes.
late on adult diabetes, late autoimmune diabetes in adults.
Yeah.
So that's a diabetes where, you know, it's not really type 1 at the beginning, but it's not really type 2 diabetes. You've got antibodies, but you present as a type 2. You've still got enough insulin and C-peptide, so you're not categorized as a type 1. But the treatment eventually becomes like a person with type 1 diabetes. We then have MODY, mature onset diabetes of youth. They're usually caused by single gene mutations. Some of these forms of MODY, maturity onset diabetes of youth, are very, I don't want to say benign, but don't cause a lot of issues. So MODY 2, which is the glucokinase mutation, has a very, very mild phenotype. A low-grade hyperglycemia, which has absolutely no effect on complications and doesn't need any treatment. Whereas you've got the other MODYs, which are a lot more severe in their glycemic control. And then we've got pancreatic forms of diabetes. So you can get pancreatitis, or you can get other reasons for killing your beta cells that then cause acute diabetes.
Okay, so after we have a chat, we will have a live segment, and that will actually involve some people of the same family who have MODY 3. So it's really exciting that we are actually going to get to speak with some people who are living with MODY, and their story is really fascinating. So, and the other thing that's really interesting is that there is such a really strong genetic component in there. It's like it's really throughout the whole family. Why does that happen? What's the story behind that?
Well, MODY particularly is a genetic disease. So we know that there are very specific single gene mutations that cause MODY, and there's about I've lost count. Maybe there's about 10 or 12 different genes that can cause this thing called MODY, and it's probably a recessive disease. So it flows in the family.
Yes.
So that's why, or probably it's a dominant disease. So that's why it can travel in families, and the doctor needs to be acutely aware of these. So get a very good family history. Look at the family tree. Look at the age of onset of the disease, and usually it occurs around about the same time. And then look at the actual symptoms. And we do have in Australia very good genetic tests that can be done to identify MODY as opposed to, say, type 2 diabetes, because if you have MODY, then the management of the disease is different to if you have, say, type 2 diabetes. So it's really critical that we get the diagnosis correct from the beginning.
And treatment for different types of MODY, different MODYs. I'm not sure what the collective now is there, but
different types of MODY.
Different types of MODY is different, right? It's not like it's like, okay, you have MODY and we can't put it all in together and say this is how it will be treated. It will be different depending. Right. Okay, and so what do some of those treatments look like?
Look, I think mostly with MODY, it's sulfonylureas, or it can be insulin. Yeah. Because mostly these genes affect the pathway of either making or releasing insulin. But as I said from the beginning, if you have MODY as a result of the glucokinase gene mutation, then you don't need any treatment. So it's really critical that we actually understand what is the genetic background for your MODY, so that then we can actually tailor the treatment accordingly. Now, it's the same with type 2 diabetes, and we can go back to type 2 diabetes because it affects 85–90% of people. There's 1.25 million people in Australia with type 2 diabetes, and again, we haven't quite gotten to the point where we can do genetic tests to say, okay, you've got this type of type 2 diabetes, so your best
have we lost Sof?
management is X or Y. I'm actually still here.
You are, but I think we lost you for a little bit of that, or maybe it's me who we lost. I'm not exactly sure. I'm in the office today. It's the first time I've been in the office to do one of these. So I'm wondering if our Wi-Fi is on a bit of a go slow.
I can go back and say to you that, you know, it's really critical that we manage MODY appropriately, because, as I said, the glucokinase, if you have the glucokinase mutation, then you don't need any treatment, because we know that you're not going to get complications. It's a very low-grade hypoglycemia. It doesn't cause any issues. But if you have one of the HNF4 alpha mutations, then yes, you do need management. And usually the management, as I said, it's because it involves the insulin production secretion pathway, usually, or signaling. Usually the best management is insulin or a sulfonylurea for MODY. And as I was trying to say before, it's the same with type 2 diabetes. Type 2 diabetes is the major form of disease. It affects about 80 or 90% of the people with diabetes. 1.25 million Australians have got type 2 diabetes that we know of on the NDSS, which is a wonderful resource. And everybody should be registered on the NDSS. I just want to make that clear. Every person who has diabetes must be registered on the NDSS so that we can understand and we can provide the appropriate resources and support.
Yep.
We know that there's various forms of type 2 diabetes. So if we can understand the genetics of type 2 diabetes, then we can tailor the treatment, the management to that person individually. So we individualize the management.
Yeah. Now, my next question is around diagnosis of these different types of diabetes, because I'm guessing, I mean, we hear, unfortunately, even when it comes to type 1 and type 2, we hear about missed and misdiagnoses. So we know that there are a lot of people with type 1 diabetes who are misdiagnosed with type 2, especially if they develop symptoms as adults. Would it be the case that there are a lot of people with MODY who haven't been, you know, that's not what they've been diagnosed with? They've been diagnosed with a different type of diabetes?
Yes. So let's just go back to basics. Mm-hmm. So the clinical diagnosis of diabetes is an elevation in your blood glucose level. So if your fasting glucose is 7 or more, mm-hmm. or if your HbA1c is 6.5% or more, then you're diagnosed with diabetes. So, so Renza comes in, we've done the test, you've got a HbA1c of 6.9, you've got diabetes. Okay. Right. Now comes the point of, okay, what type of diabetes? Is it a type 1? Is it a type 2? Is it something in between, like a LADA? Is it MODY diabetes? So then it's the clinical acumen of the clinician that then differentiates, and the history of the patient that then provides the information about which forms of diabetes, as well as further tests. So we may do, for you, we may do antibody tests and figure out, yes, you have hyperglycemia, you've got antibodies to the various stuff that we know for type 1 diabetes, and also you've got very low C-peptide or no C-peptide or no insulin at all. Okay, that's classic type 1 diabetes.
Right.
For the MODY forms, it's a little bit trickier. Mm-hmm. So you've got to get a family history. You've got to look at all these blood tests as well to exclude type 1 diabetes. And then you may, given the response of the person to medication, so if you think it's a type 2 and it usually looks like a type 2, you put them on metformin, they don't respond, usually then you think, oh, well, okay, maybe it's a MODY, maybe I should actually then do a genetic test to figure out whether that person has MODY or not. But depends on your family history, it depends on the presentation, and then it depends on your responses, sometimes on the response that you have to the normal medications that we would give to a person with type 2 diabetes.
Okay. And can treatment change? So we know that in type 2 diabetes, people might start being treated with one thing and then they might start. So it might be, to start with, it might be looking at being more physically active and changing your diet. Then it might be about some oral medications, and then it might be insulin. What about with MODY? Can there be a similar progression where you start on something and then later on it might be different?
Yes, it may change, and it depends on the person and how that person responds to the medication. Now, let me just make it very clear from the beginning. Diet and exercise is wonderful for all forms of diabetes, no doubt about it.
Everyone, even if you don't have diabetes. Yep.
Even if you don't have diabetes.
Yep.
So diet and exercise is something that we advocate from the beginning of your diagnosis or your pre-diagnosis right through your management.
Mm-hmm.
Be mindful that none of the drugs that we have treat the underlying cause of the disease, whether you've got type 2 diabetes, whether you've got MODY. So we don't have a specific drug that will fix your HNF4 alpha genetic mutation. So by design and by default, some medications will work with some people, and you may have to change them and up-titrate or alter or add things or take things away to get good control. So just be mindful that what we're doing is we are actually managing the disease as best we can with the available armamentarium. I call this, we've got guns here, we've got this gun over here, and we've got that gun over there, and we've got that gun over there, and we're trying to use them in combination to get the best outcome we possibly can. And you know, I got to tell you, I've been in diabetes since 1990, so 32 odd years, and the progress that we've made in medications, in understanding how to use the medications, and then in technology, which we can also talk about, you know, flash glucose monitoring, continuous glucose monitoring, insulin pumps, has been outstanding, amazing.
Yeah.
And I would encourage, even if you have MODY, I would encourage somebody to use an FGM or a CGM for a couple of weeks to figure out what regulates or what affects your blood glucose levels, your exercise, your food, your sleep, your alcohol intake. We don't drink alcohol. No alcohol here. We don't drink alcohol. Your alcohol intake.
We'll come back to that in a minute, but anyway.
Your coffee intake. Coffee is good for you, but coffee with 3 tablespoons of sugar may not be that good for you if you have diabetes. But so I think if you can get an insight into your daily living and what affects your blood sugar levels, that really gives you a very powerful insight. And we should be using technology to give us that level of information so we can manage our diabetes much, much more effectively. Yeah.
I'm just going to add that even if you don't have diabetes, if you're having 5 cups of coffee with 3 teaspoons of sugar in it, that's you know, I think that people with diabetes, we keep getting told what we shouldn't be eating, and I really wish people wouldn't do that. But hey, if people are going to keep telling me that, I'm going to tell people without diabetes as well. And if people want to drink alcohol, they can still have a glass of wine with dinner, right? You're not telling us that that's not okay. Please don't.
You can have a glass of wine, but as long as it doesn't become the bottle of wine. So a glass of wine is fine.
Again, beyond just diabetes, we're giving public health messaging now.
For anybody. So, and I think and you will see, if you wear a flash glucose or a continuous glucose monitor and you have alcohol and you have, you know, whatever, you'll see it. You'll actually see it.
Yes,
right?
absolutely. Yeah.
Something happens.
Yeah, there's so much information that we get that, you know, I think that one of the things that I say is that since wearing a CGM and also using a closed loop system, I realise how little I know about diabetes, because this has just given me so much information that I just couldn't have seen before.
Right.
Yeah. Yeah. Now, so I want to ask about, as people diagnosed with type 1 diabetes are often referred to an endocrinologist. Type 2 is often the health professional that you see will be your local general practitioner and GP. What about when it comes to those other types of diabetes? Who would we suggest that people see as their health professional to work with them through this?
Look, I think because if you have MODY, or if you have LADA, or if you have pancreatic induced diabetes, I think the best person to look after you is an endocrinologist.
Yeah.
Because the endocrinologist actually knows and understands the disease process a lot more intimately. So I would encourage all GPs, if they feel that they've got a case that looks a little bit difficult and the case isn't responding to medications and there's some inconsistencies, refer on to an endocrinologist, and then the endocrinologist will be able to do the appropriate tests and the appropriate investigations to figure out what type of diabetes it is. As I said, it's really critical. If we know what type of diabetes it is, then we can actually provide a little bit more effective management of disease with the existing therapeutic agents that we have.
And as the person living with conditions, knowing your medical history and what's going on and what condition you have is so important, because it's important for yourself and making sure that you are getting the right treatment, but there could be huge implications when it comes to the rest of the family, especially when we're talking about something like MODY, where there is this genetic component here as well. So I have another question. We've spoken quite a lot about MODY and a bit about LADA, but let's talk about diabetes that happens because of pancreatitis or something else that's happened in pancreas. So does that happen? Can that happen quite quickly? Can that happen from a trauma?
Yes, it can happen from a trauma. It can happen from cancer.
Yeah.
So if you have cancer and part of your pancreas is cut out, and so you can have a total or a partial pancreatectomy. And depending on how much of your pancreas is removed, then depends on how severe your diabetes is. The most severe diabetes, where you have a total pancreatectomy because of a cancer, and then you need very aggressive management of the disease, including your exocrine pancreas and the exocrine enzymes that go to aid digestion. So that's the extreme form. Partial pancreatectomies affect diabetes a little bit, or affect your blood glucose levels a little bit, and the usual management of that is insulin. So most people are on insulin, and you need to make sure that you have enough glucagon flying around so that you can prevent the hypos that will come with the administration of insulin.
Okay. Now, you mentioned earlier that anyone who has any type of diabetes should be on the NDSS, and I would just say that there are categories on NDSS forms for other types of diabetes. So it is absolutely critical that that we know who has diabetes in Australia. The NDSS, the data on the NDSS is such an incredible tool for us to be able to see numbers and see how people, to know where people are, to know what type of diabetes they have, to get a snapshot of what's going on in Australia at the moment. Yeah.
Absolutely. I cannot stress enough that if you have diabetes and you're not registered, please go and register. Please go onto the website, or please go to your diabetes health professional, GP, and get the form signed and registered. It is absolutely critical. It is what we use to support the person with diabetes, for us to go to the government and say, can we please have a little bit more support in this area or in that area? The NDSS is absolutely critical.
Yeah. Yeah, and it's unique to Australia, so it's it's something that we are able to use in such great ways. So two things here I just want to say: if this, if you're listening to this and saying, "Hey, that's me," a couple of things. One, if you're not on the NDSS, please register. You need to talk to your health professional to register on the NDSS. And two, if you're thinking, "Hang on a minute, I think I might need to see a specialist here, and my GP has been great, but perhaps this isn't their area of expertise," ask for a referral. You absolutely can do that. And so if your GP is not doing it, just say, "Hey, would it be okay for you to write a referral for me?" Sometimes we have to advocate for ourselves.
Absolutely. And let's just be mindful that the GP is wonderful.
Of course they are.
GP,
Thank you so much.
is absolutely terrific.
Yes.
But they are managing 135, 150 different diseases, illnesses, conditions. So we cannot expect them to know everything about it. So that's why specialist is really, really important.
Absolutely.
Your annual cycle of care, Renza. Make sure you go and get your feet checked. Make sure you go and get your kidneys checked. Make sure you go and get your eyes checked.
Yes.
Do your blood lipids, your blood pressure. All of that stuff is really critical to ensure that you're getting the best possible management of this. Remember, we're trying to prevent or delay complications.
Yep, and that's the case for all types of diabetes. Those screening checks are really important. Screening checks are important. GPs can facilitate that. So, you know, having a local GP who is that, you know, that family doctor, the idea of, you know, you can go to see them for all the other stuff, but if you do need specialist care, ask for a referral. That's that, and they will be able to help you. I've got a great GP, but we know the rule. They're not allowed to talk diabetes with me because I have my diabetes specialist, but all the other stuff, that's what we do. So, and that's probably where I'm going to be getting my COVID vax too. I get my flu vax there every year. So this has been so enlightening and so brilliant. And I'm thrilled that we're going to be speaking with a family who has Modi, and they're going to be telling their quite remarkable story. So we will be doing that now. But thank you so much for joining us from the car. I should have done this from my car, and then we could have pretended we were doing like a carpool karaoke thing. We'll do that next time, okay? But thank you so much. And Emily, we'll end this little bit and work out how we're going to snap this all together with the live bit that's coming next.